Good afternoon. Welcome to the last oral session of the day. So I'm joined by my co-chair, Professor Gattuso, who is the professor and former director of the Tropical Medical Institute in Peru, and currently the emeritus professor of medicine at Cayetano Heredia. My name is Divya Dashmana. I'm one of the consultants that work in the HTLV clinic in London. I'm a consultant physician. Before we start, can I remind you that the login for Slido is on the back of your programs. So please take a minute to log in, and then you can ask your questions. You can type your questions as you go along.
Okay. You know, because we are seeing so many comorbidities with our patients, we need to learn about that experience. And today we have some abstract dedicated to see what lesson we have about the other infection or other comorbidities. The first one is coming from Brazil, the use of art associated with reduced HTLV provirus load and the co-infection with HIV is Dr. Carlos Brites from the School of Medicine, the Federal University of Bahia, Brazil. Carlos, welcome.
Good afternoon. I thank the organizers for the opportunity to present our results on the use of ARTIS in HIV/HTLV co-infected patients. This is my disclosure. Well, we know a lot about the consequence of HTLV infection. However, after almost 50 years, we have nothing to treat the infection itself. So we have some previous work using antiretroviral therapy for treatment of HTLV infection, but the results are still very controversial. And the fact is today to have no treatment available for HTLV infection. We have some previous work on RT use in such population. Some in vitro studies a few years ago showed some very scarce results, and most of them did not provide enough details to understand what could be the effect of RT use on HTLV co-infected patients. And some clinical trials also in the recent years use an NRTI drugs that we commonly use for HIV treatment, and also using some newer drugs like the integrase inhibitors class, especially Haltegravir. You see that the previous studies with AZT and 3TC or 3TC alone did not provide any clear benefit for treated patients. However, the number of patients included in these studies were very small, and the follow-up time also was short. So we have some limitations of these studies. Regarding the studies using Haltegravir, we have two recent ones, Trevino, showing an initial reduction in HTLV proviral load in the first 6 months, but with the viral rebounding after this, to baseline values after this period of time. And another one more recently from Enusa Akahata in 2021 showed that there was no change in proviral load, but when they performed a subgroup analysis in MTSP patients, you was seen a benefit with a reduction in proviral load after 6 months of medication use. We have some clear problems in using ART in HTLV patients, especially for designing proper clinical trials. First of all, most of the pharma companies are not interested in this specific disease. And I personally try to get some support, at least for providing the drugs for treating patients, but no was the usual response. In addition, you have a concentration of cases in low and middle income countries, which means less access to funding support for clinical trials. And as we could see in the previous slide, there is still a lack of evidence on potential benefit of antiretroviral use in this population. However, we realized that there is a population that's prone to be evaluated because HIV co-infected patients must receive antiretroviral drugs to treat the basic disease, HIV-1. So it would be the ideal population to look at the eventual benefit of ART use on outcomes. So the main objective of our study was to evaluate the effect of antiretroviral therapy used on proviral load of HTLV co-infected patients. And it was a cross-sectional study conducted in our site in Salvador, Brazil. Salvador is the capital state of Bahia, which is considered the epicenter of HTLV infection in our country. And we selected people living with HIV over 18 years of age with a Western blot confirmed co-infection by HTLV-1. And for comparison of proviral load, we use a group of single HTLV-infected patients without any experience with antiretroviral therapy. And the main assessment were clinical and socio-demographic characteristics, and we compare proviral load and CD4, CD8 count for both groups. And we try to evaluate if the time on ART could impact the effect of antiretroviral drugs on proviral load of these populations. Initially, we selected 57 co-infected patients, but only 41 were included in the study because 2 did not show up to blood collection, 7 tested negative by Western blot, and 5 were double positive for HTLV-1 and HTLV-2, and we would like to exclude the HTLV-2 in this study, and 2 were positive for HTLV-2. The main characteristics of the patient are summarized in this picture. Most were female, 63%. 97% were non-white. Salvador is considered the largest black city outside Africa. Most of the population, over 85%, declared themselves as black or mulatto. They had a low education level, and 3 were ART naive in the patients because one of them were elite controller, and the other 2 did not start at that time antiretroviral therapy. And 25 of them were on dolutegravir-based regimen. Well, initially you could see that patients using integrase inhibitors had a proviral load 3 times lower than those on other ART regimens. So you can see that on NSTI was 6 to 2 versus over 200 in patients without dolutegravir experience. And we observed that there was a negative correlation between age and proviral load. Older people were likely to have a lower proviral load, but we could also define that most of these individuals also were a longer time on antiretroviral therapy. There was a clear association between longer time and older age, of course. And we select a group of 36 HTLV patients to compare proviral load. And you can see here the main results. And age was all patients with. First, we should say that we define arbitrarily median as a set point to define high proviral load or lower proviral load. So we see that patients with no low proviral load were older than, significantly older than those presenting with high proviral load. And they also were, there was an association between female sex and higher proviral load. And patients on integrase inhibitors were more likely to have to be classified as low proviral load in this group. And there was a clear difference in terms of time. I'm going to show in the next slide, because the effects of integrase inhibitor were more apparent earlier than those in patients using other ART regimens. This picture summarizes the results. You see on the left side the percent of high and low proviral load by exposure to ART. And less than 6 months, you see that most of the patients had more than a median proviral load. And when you have 6 months to 10 years of ART exposure, there was an inversion. And 10 or more years of ART exposure, you have inversion compared to the baseline results with more patients in the group of low proviral load. And when we compare the same groups, according to the use of integrase inhibitor, we have a very similar picture. Less than 6 months, more patients with high proviral load, but as early as 6 months to 18 months, we have an inversion with more people in low proviral load if they were using dolutegravir, and more than 18 months, again, the same trend was observed. So ART-naive patients, regardless of co-infection status, had a higher median proviral load than those on antiretroviral therapy. And you can see here the values, 34 copies versus 59. And here, a summary of the results with median proviral load according to any ART use. Patients on ART had a very low proviral load compared to those that were ART-naive in their life. So our conclusion is, despite the controversial results in the literature, our study suggests that antiretroviral therapy could be an option for treating such patients. Of course, this is a pilot study, and the sample size limited our conclusion and has reduced the power to detect difference between groups. And we believe that it's time to design large trials, well-controlled, to try and to test this hypothesis, and maybe it could be an option to treat patients from now on. I thank my lab team. Lab is our clinical research unit, and the Brazilian Ministry of Health who donating the dolutegravir to be used in this trial. Thank you.
Thank you, Carlos. We go to the basic science on this. The next presentation is dolutegravir and tenofovir lafamine block the HTLV1 transmission in vitro. It is time to eradicate HTLV1. Dr. Calimera from the Imperial College from UK will present.
Hello. Thank you for inviting me for the talk. So I'll be talking about my work trying to figure out whether dolutegravir and tenofovir, which is second-generation ARVs, work against HTLV1 in cell culture. I have no conflict of interest. So just a quick fact sheet on HTLV. It was first discovered in 1980 and was, in fact, the first retrovirus to be discovered, and is the causative agent of, as you heard, ATL and HAM-TSP. So like other bloodborne viruses, it is transmitted via penetrative sex, injectable drug use, and the use of contaminated organs in transplantations. And it also transmitted from mother to child vertically during birth and breastfeeding. There's currently no approved specific HTLV1 therapeutics or preventatives, and this is likely to its use, to its global distribution to the global south. So, however, the burden stemming from HAM-TSP and the mortality of ATL necessitated the development of prophylactics or preventatives. So, like I mentioned, HTLV1 is a retrovirus like HIV, and this is just a EM microgram showing HIV particles and HIV1 particles from the same patient. So, unlike for HTLV1, drugs have been developed for HIV. These drugs target a life cycle of HIV. So just we could go through. The virus attaches to the cell surface, and then it internalizes via endocytosis, and then the entry is completed when the cell membrane and the viral membrane fuse to release the core particle into the host cell. This initiates reverse transcription, which is performed by reverse transcriptase, an enzyme. This makes new viral DNA from the genomic RNA. The viral DNA is then internalized into the nucleus, where it is then integrated into your host DNA by an enzyme called integrase, and this leads to stale formation of a provirus. This provirus can then be transcribed and translated by host machinery to make new viral particles. So, as you've heard in the previous talk, past work to identify whether antiretrovirals do actually have an effect on HTLV1 focus largely on preventing disease or alleviating the symptoms of HAM-TSP. And invariably, in most cases, they found that these drugs were not active against, could not alleviate symptoms of HAM-TSP or improve prognosis of patients living with ATL. This is explained, well, most reasonably explained by the fact that in the very beginning, during your few months of infection, HTLV1 is maintained via cell-to-cell spread. And it is at this point where ARV drugs are actually active. However, in the later stages, chronic stages, like past 3 months of infection, the virus is mostly maintained by mitotic spread. So the virus is integrated into the genome and is therefore imprinted and maintained via mitosis. So as the cells divide, the provirus will be present the entire time. So based on this, ourselves and others have done some initial cell culture experiments to see whether antiretrovirals can actually block cell transmission in cell culture, cell-to-cell transmission in cell culture. This was done in 2005, and they actually found that tenofovir was active against HTLV1 transmission. This is our work done in the past 4 years. We've seen that first and second generation INSTIs, which are integrase inhibitors, actually block HTLV1 spread. Our most recent work showed the second generation INSTI also blocks HTLV1 spread in cell culture. So going from this, we wanted to question whether the individual constituents of the current recommended first-in-line HIV CRT, dolutegravir, and TAF, or tenofovir are also active against HTLV1. We also tested whether the transformative lenacapavir drug, which can be used, you inject once or twice a year, and are able to suppress HIV. So we tested all 3 reagents in cell cultures. For our infection assay, we cultured a cell line called JERCAT. It's an immortal T cell line with tenofovir, dolutegravir, and lenacapavir at increasing concentrations. And then we culture the cells with a producer MT2 cell lines which infects the JERCATs. We then remove the MT2 cells and then culture the JERCATs for around 12 days. At 12 days, we then harvest the genomic DNA and then measure infection by measuring genomic tags and genomic GAG, as well as human albumin control. So the first molecule we tested was TAF. Tenofovir is just the most recent prodrug of tenofovir. So tenofovir is a reverse transcriptase inhibitor. So here I've just shown the structure of HIV1P66, and this is the alpha model I generated of HTLV1 RT. And as you can see, the active sites look quite similar, but more importantly, the residues that are evolved in binding tenofovir are entirely conserved between HIV-RT and HTLV1-RT. So this gave us the indication this drug is likely to work at preventing spread of HTLV1 in vitro. And this was the case. As you can see, at the highest concentration of the drug, we're able to completely abrogate infection. And this is a measure of proviral. We're measuring the amount of TAX TAX genes present in the cell. And we're able to achieve an EC50 of around 15 nanomolars, which is great, actually. We then measure integration by first amplifying the genomes with ALU element primers, and then we then measure for HTLV1 GAG, and then we found very little integrations at the highest concentration of drugs. So this data do suggest the ARVs, specifically TAF, can prevent HTLV1 transmission in culture. Next, we tested the dolutegravir. So here is just the zoom in on the active site of HIV and HTLV1, a close relative of HTLV1. This is the intersome, basically the integrase enzyme. And here they're bound to a drug called bictegravir, which is a close structural derivative of dolutegravir. And as you can see, when you compare the HIV and HTLV1 binding modes, the drug is binding in a very similar fashion or configuration. This gives us the promise that the drug would be very active against HTLV1, and that was proven to be the case. We were able to achieve an EC50 in the picomolar range following infection, which is actually better than what we found for HIV. Furthermore, when we looked at integration following allo amplification, we're completely able to inhibit infection or integration of HTLV1 in cell culture. So next, we tested the reagent called lenacapavir. So lenacapavir binds P24 of HIV, which is the capsid protein. So here I just generated a model of HTLV1 P24 and HIV1. So this is an actual structure shown here in red, and this is a model I got of AlphaFold. And importantly, when you overlap them, you can see that the residues that are important to binding lenacapavir are absent in HTLV1 P24. We tested it, and we see no effect in lenacapavir's ability to inhibit infection. So this drug is inactive against HTLV1. As a control, we see that it's active against HIV. So lenacapavir does not, or is unlikely to make a good candidate for an HTLV1 antiretroviral. Next, we then tried our infections in primary cells. So for this, we got 6 donors to give us the blood, actually the T cells from them, and then incubated this with the drugs for 3 hours, and then infected the MT2 cells, expanded at 12 days, and this time we use flow cytometry to measure infection. So we measure for the amount of TAX present in cells. So TAX is a HTLV1 protein. This is just a summary of the data. At the highest concentration of drug, we're able to completely block HTLV1 transmission to primary cells. And at the concentration where we got the inflection point of the previous curves, we're able to reach 10% of infection when you incubate with this concentration of drug. So this data show that we can actually prevent transmission to primary T cells. And this is important because Jurkat cells are a uniform line because they've been cultured forever, but with primary T cells will maintain some heterogeneity when you culture them and infect within the first 6 hours. So this is a summary of all the data from our lab showing that INSTIs are active against HTLV1 with comparable or better EC50s compared to HIV1. And lastly, all tenofovir prodrugs here, TTF and alafenamide are also very active against HTLV1 in vitro. So we think that INSTIs and tenofovir prodrugs will make wonderful or potential anti-HTLV1 drugs and should be tested using patient cohorts. I want to thank my lab and everybody else. And, cheers.
Thank you, Dr. Kalema. Thank you.
Professor Grassi, are you all right to go on, or do you want to go? You're fine. Okay. I'd like to introduce Professor Fernanda Grassi, who is the Medical Director and Specialist in Infectious Diseases in Bahiana School of Medicine and researcher at Fiocruz, Bahia. Thank you.
Okay. Good afternoon. First, I would like to thank the organizing for giving me this opportunity to be here to present our results from Bahia, Brazil. Okay, so I am telling you today about the susceptibility of HTLV-infected women to HPV infection. I have no conflict of interest, and I would like to start to tell you, I know you know that, but HTLV has a profound impact in humans' lives. Not only because they are more infected by HTLV, because they have more risk to have disease associated with which has anti-SP, urinary disorders, depression, but also they have the possibility to transmit the infection to the children, and this is very impacting. Our group has been interested in studying the sexual dysfunction and the health sexual in this human. And we had the opportunity to show that there is a decreased vaginal lubrication, especially in women with anti-SP compared to asymptomatic women. Also, there is a sexual dysfunction in these women. The HTLV proviral load is detectable in vaginal fluid and is correlated to proviral load in peripheral blood. This could be interesting. And we have also an inflammatory in vaginal environment with increased level of Th1, Th2, IL-17 cytokines in vaginal fluid, even in asymptomatic individuals, in asymptomatic women. So we know also that women have are more prone to have other sexually transmitted infection. And with HTLV, we know in previous work in Brazil that there is a higher prevalence of HPV in HTLV-infected women. And we know that cervical cancer is highly associated with HPV. And in this study, we try to look for the prevalence, but also to analyze the types of HPV in HTLV-infected and uninfected women. So we conducted this study in Salvador, Bahia. Brits already tell us about this city. It's considered the epicenter of the infection in Brazil. We have 2% of people infected, and 10% of women are more than 50 years old, which is a huge proportion. And we included all patients that had HTLV confirmed by Western blot, had more than 18 years old, and had a sexual life active. So we exclude those who were infected with HIV or vaccinated for HPV, pregnant, breastfeeding, or situation that could impair the immunity. So the unaffected group was person that company or relative of these patients and have the same criteria in age and sexual activity. So the patients were included and examined by a gynecologist trained, and at this point we collected blood and also cervical vaginal sample to perform cytopathology studies and the HPV genotyping. So we use the Papa Nicolau staining for cytopathological analysis with Bethesda system. We do first conventional PCR for identify positive samples, and then we do genotyping by next generation sequencing and also Sanger. So here you can see the profile, the socio-demographic profile of these women. We had no differences between regarding age or skin color or drinker, etc. Regarding clinical characteristics, sorry, and sexual behavior, we have a difference in the frequency of sexual intercourses in the week. So the number of partners in lifetime, that it was higher in HTLV-infected women, but the number in the past 6 months was not higher compared to non-affected. And there were no differences between previous STI story, no difference, or treatment for HPV, no difference, or painful and during intercourse, or bleeding. So regarding condom use, we have a tendency of human infected using less than unaffected one. Regarding the frequency of cervical and cytopathological findings and HPV infection, we can see here there is a little difference. The double of women had, the women with HTLV had 2 times more, but there is no difference, so it's similar. And only 1 woman had precancerous lesion. When you look for the HPV profile, we saw clearly that the pattern is different between HTLV infected and unaffected women. And we have only 3 subtypes that are shared by both groups. And one thing that gets our attention is the HPV 58 that is much more prevalent among HTLV infected women, 38% compared to 5.5% in unaffected women. Regarding multiple infection with HPV, which are more than 4 types, we have 2 women in each group, so no really different. But the oncogenic risk groups, HPV, was more frequent among HTLV infected women, which is here in red and yellow, probable high risk. It's much more frequent than patients unaffected. In conclusion, the frequency of HPV in the cervical fluid of HTLV infected women is about twice as high as that of HTLV negative women. More than half of HTLV infected women were co-infected with a type probable or high oncogenic risk, and HPV 58 was most common among HTLV infected, in no differences regarding co-infection with multiple types of HPV and cytovaginal cytopathological analysis. However, a small number of patients. So I would like to thank all the equipe, especially Alison Aquino, which was the PhD student, and also Bernardo Galvão, who is the director of the HTLV Center, the Instituto Nacional do Câncer in Rio de Janeiro, that performed for us the sequencing, and all the equipe. A special thanks to the patients that inspire us, Adriane, and the association HTL Vida. Thank you, Adriana. Thank you, Márcio. Laurides. And I would like to invite you to Brazil in October 24, 25 for our International Brazilian Symposium. Thank you very much.
Thank you. So I'd like to invite Dr. Daniel Bradshaw, who is a consultant virologist working at the UK UCSA, Health and Security Agency, and is also an honorary consultant physician at the HTLV Clinic in London.
Okay, thanks to the organisers for inviting me to present these data. So the title is Infants of Hepatitis B surface antigen positive women in the UK are at risk of HTLV1 acquisition. I don't have any conflicts of interest. So we've seen over the last 30 years that the numbers of patients diagnosed annually with HTLV1 has gradually increased from around 50 to 60 per year in the 1990s to around 90 per year in the more recent decade. And these are data from the National Reference Laboratory. We've also recently re-estimated the population living with HTLV-1 in England and Wales. So although these are still fairly crude estimates with wide ranges, this has gone up from around sort of 15,000 in 1991 to 36,000 in 2021. And these are estimates based on census data using country of birth. So it's clear that the majority of patients are not being diagnosed and are unaware of their infection in England and Wales. So we wanted to look at a population with another blood-borne virus infection, which is hepatitis B. Clearly, there are shared routes of transmission, and therefore it's quite plausible that we might see higher rates of infection than in the general population. So we took advantage of the hepatitis B antenatal screening program, which the UK, as many other countries, runs. It's a very successful program with over 99% uptake of hepatitis B surface antigen testing. And so there are 650,000 pregnant women on average in the UK each year, and of those, 0.3% are diagnosed hepatitis B surface antigen positive. We also know that around 50% of these women were originally born in an HTLV-1 high prevalence country. So this is a screening program which looks for an oncogenic virus. Women who are diagnosed positive can be recommended treatment, and their babies can be sort of given an accelerated vaccine plus or minus immunoglobulin to prevent transmission, with the ultimate aim of preventing hepatocellular carcinoma in the infant. So we were able to access blood that's collected from both the mother and the infants. And the reason it's collected as part of a Hep B enhanced surveillance is to allow a number of investigations, for example, in utero transmission, where the sequencing the Hep B DNA can be detected in the neonatal blood spot. So the aim of this study was to determine the seroprevalence of HTLV-1 and HTLV-2 in hepatitis B surface antigen positive women in England and Wales. So this was an unlinked anonymous seroprevalence study. And as I've mentioned, the population is shown here with samples collected between March 2021 and June 2022, and we were using residual specimens. The testing was performed with the Murex ELISA, and then any samples that were indeterminate or reactive were confirmed and typed with the Western blot. And we had access to fairly limited demographic and clinical data from the surveillance database. So these are the characteristics of the individuals that were tested. There were 1,790 women with a median age of 32. 38% were of Black African ethnicity, 31% white, 26% Asian, and 5% other, and the vast majority had antibodies to hepatitis B e antigen. We had birth country or region data available for 1,679 women. A third were born in Africa, 32%, a third as well, born in Europe outside the UK, and then smaller numbers from the other WHO regions. And the top 5 countries of birth for women involved in this study were Romania, Nigeria, Ghana, Pakistan, and China. And as we expected, it was just under half were born in a high prevalence country for HTLV-1. So there were 5 women who tested positive for HTLV antibodies on the ELISA. The first was considered to have non-specific reactivity because the Western blot was completely negative. The other 4 did have reactivity for HTLV-1. In fact, all the HTLV-1 bands were positive. The first individual was of Black African heritage, country of birth unknown. The second, again, Black African heritage, born in the UK. The third individual, Black African heritage, born in West Africa. This individual, there was a trace band at RGP46-2, so we couldn't exclude HTLV2 co-infection, but we considered this was relatively unlikely. And the final individual was of Black Caribbean ethnicity, born in the UK. So overall, the seroprevalence for HTLV1 in this cohort was 2.2 per thousand, with a 95% confidence interval of 0.6 to 5.7. Obviously, these are small numbers, but looking at individual seroprevalence according to country of birth was 1.3 for those born in an endemic country, 2.2 for those born in a non-endemic country, which include the UK. And then for those where the country of birth was not known, was higher, but the confidence intervals are so wide, you can't really ascribe any significance to that. So over 5 years of the surveillance, if there were just over 7,000 women sort of taking part, we estimate that 16 of these would have been HTLV1 seropositive. And assuming a vertical transmission rate of 20%, 3 infants probably and avoidably acquired HTLV1. All of these women were likely of Black ethnicity, for which the estimates are that breastfeeding rates at 6 months or longer are around 60%, so in the higher risk group for transmission. And of relevance to this, there is an antenatal proposal for a targeted screening program for HTLV, which Carolina Rosada and others have recently published, which would be according to country of birth of the woman or their partner's country of birth, and that would be cost saving, and that's under review by the National Screening Committee. We looked for other studies which had described epidemiology of HTLV and hepatitis B co-infection, and as you might expect, there weren't a huge number of studies, but I've shown here on the left studies reporting the percentage of HTLV1 seropositivity in Hep B surface antigen positive individuals, and most of them were from Brazil. The study, interestingly, from Papua New Guinea, they found that the highest seropositivity in Hep B surface antigen individuals at over 3%. And I should say these were from a variety of different healthcare settings. And then of what's perhaps striking on the right, which is percentage of Hep B seroantigen positivity in HTLV1 positive individuals, is the very high rates in the First Nations people of Australia, with rates there over 12%. So clearly this is, these data are limited by relatively small sample size with wide 95% confidence intervals, and we are aiming to collect more data. Obviously we don't have access to whole blood, so we couldn't generate proviral load data, and we didn't have any information about other co-infections such as Delta or HIV or hepatitis C. So in conclusion, the seropositivity of HTLV1 in this cohort is 2 per thousand. All these individuals where we had the ethnicity known were of Black heritage. Vertical transmissions of HTLV1 are occurring in this population, and clearly we do need public health interventions such as antenatal screening to stop this. I'd like to acknowledge the patients and staff involved in the antenatal screening program for Hep B, and also staff in the bloodborne virus unit and the clinical services unit involved at my institution. Thank you.
We can open the questions, please.
Carlos, I'm so happy you did this study, and I hope many others will follow suit to check how well integrase inhibitors and with or without TAF work in PEP and PrEP. But I have a question. I was wondering, did you do integration site sequencing on the samples from the patients? Because we know with HIV, when they've been on ART for a long time, you see that integration happens in silent regions of the chromatin.
We are intending to sequence all the samples you have. There is a PhD student doing this, and we intend to have a whole viral genome at the end of the study.
Phylogenome and also location within the host. Not just sequencing of the provirus, but where it's integrated into the host genome.
No, we did not that.
Okay, thanks.
Carlos, one question, Carlos, related to the, in your slide, you present heart therapy in Brazil, no? But in Brazil, in the last 6 years, you are using dolutegravir as the first line. That is important because when you mention heart, will be very important to see what heart you are using, and I feel you are using dolutegravir.
Yeah, dolutegravir, according to Brazilian guidelines, is selected only for a specific population. Those that do not tolerate dolutegravir and need an integrase inhibitor, or some specific situation like tuberculosis that cannot use dolutegravir or efavirenz for any reason. So it's a restricted drug to be used in HIV patients. The standard of care is dolutegravir-based regimens. So we probably have, maybe one of these patients could be exposed to dolutegravir transiently in the past. But since 2017, the dolutegravir is the standard of care.
Fabiola.
Hi, thank you so much to all of you. That was a really interesting, session across different fields around transmission prevention. So, question to any one of you: the role of pre- and post-exposure prophylaxis, especially in serodiscordant couples, as well as mother-to-child transmission. Do you have experience with it? Do you use it? Because obviously it's not licensed yet. We don't have any studies that are up and running. Gödel and I and all the signatories, more than 900 signatories of the petition, have been trying to work with Viv and Gilead to access those samples. But going forward, we know of cases where we do prescribe off license. I prescribe a lot of things off license as long as the patient agrees to do so. But in the HTLV setting, so serodiscordant couples and mother-to-child, the role of the PrEPs that we just discussed, particularly Truvada or tenofovir emtricitabine, where we know they are safe in pregnancy. With Instis, the modern ones we're still looking into, but in general, I would be inclined to use them if the patient agrees to be used off license. So what are your views?
Well, we discussed briefly yesterday about this. I believe it's a challenging task trying to design a proper protocol to test the hypothesis of preventive use of Truvada or any other antiretroviral drug. I believe we must do it, but we have to be careful in terms of which population to select and how design this protocol. Otherwise, we can do nothing at all. At the end, we have no useful information. But I believe it's time to advance in therapy, and we have to forget about the old concepts in terms of antiretroviral has no use on HTLV1. I guess it's time to do that, and we are trying to move forward.
Maybe I'll just add one point. I mean, it's almost a cliche, but I think what is needed is international cohort, so international collaboration, because the concerns that have been raised in terms of generating robust data around efficacy of PrEP are that compared to, say, HIV, the transmission rates are lower, so the numbers of patients and the follow-up duration will be greater, and that can probably only be achieved by having really excellent collaborative links across multiple countries, and as well as a kind of groundswell of opinion to persuade pharma companies and others to kind of fund and resource these kind of strategies.
I
They were amazing talks. I have one question for Pat and a question for Dan. For Pat, did you at all look, or are you planning to look at all in vitro at any cumulative effects of giving multiple different ARTs? So, for example, kind of TAF plus bictegravir or TDF plus dolutegravir, and then I'll ask Dan's question afterwards.
We haven't done that just yet. We're doing something slightly different where we actually get in patients on, not patients, people taking PrEP in London and then trying to infect those cells as a in case of actually a clinical study. So maybe there's no combination PrEP at the moment, but we'll hopefully we're trying our best eventually to maybe get some people on long-term cabotegravir as well as Truvada. But this is further down the line. For the moment, we're doing Truvada, in Truvada, pre-treated cells from in the patients, then infected them. So combination-wise, I mean, it's clear, so working individually to see if there's a summative effect. I don't see the value of it personally, as in to do an extra study of that, because individually, all performance are working. We haven't tried embritricine, I can't say the name. It's the only one in the DTG, TAF, embritricine that we haven't tried, because the two are working very well. I'm very confident that it'll work.
You're not looking at, say, Truvada DF plus emtricitabine, because that would be equivalent, but you're just doing the PrEP trials for patients?
Yeah, at the moment, it's purely based on Truvada.
And then, Dan, I had a question for you. I might have just slightly missed it on the slide. Your slide with the number of people that were HTLV, found to be living with HTLV and also Hep B surface antigen positive, were 2 out of 4 of them UK born? Because is there a concern if we're screening only for people by country of birth, we're actually going to be missing half the people living with HTLV in the UK in pregnancy?
Yeah, so we had ethnicity data on all 4, and they were all of black ethnicity. Yeah. But when we had country of birth data for 3 out of 4, 2 were UK and 1 West Africa. So yes, if we had targeted screening only by country of birth, there is a worry that we would miss these individuals. So I think the proposal should, from this data and others, include other aspects as well. For example, hepatitis co-infection might be another one, or it could be that other sort of family members, so second generation country of birth or ethnicity may be other factors to include. So yeah, I think any start would be great to build on, but yeah, we need to get the model right, absolutely.
Thank you.
Just coming back to Fabiola's question, so the practice in clinic when we see serodiscordant couples, so often serodiscordant couples have been together for a very long time, and by nature of whatever, they remain serodiscordant, and often they don't tend to use condoms continuously. They tend to go with the risk saying, well, I've been together for 20 years, I'm fine. But I think we do need to have a conversation about the use of PrEP, particularly when it comes to conception. So I think that's what we should be talking about to our patients. We, in the clinic, we offer PEP after needle stick injuries. So that's something that we're trying to carry out within our hospitals. And I think, again, we need more information on the use of PEP and whether I'm overusing it or underusing it. So we need more information, again, collaboratively about that too. I've got some questions on Slido. So for Dr. Breeth, what is known about HIV, HTLV co-infected patients and their risk of HTLV-related inflammatory disease? Is it known if ART use modifies this risk? So does ART use modify the risk of HTLV-associated inflammatory disease? Do we know?
I invited this on Wednesday. We're going to have a presentation on a trial we are doing comparing dolutegravir versus vitamin C in HTLV-infected patients. And the preliminary results, 24 weeks, are very interesting and can provide some information on this specific question. So Wednesday, it is Castellón will you present this.
Pablo, question.
Dr. Carlos, what is the protocol used in Brazil for antiretroviral treatment in children with HIV and HTLV1 in children?
We have no protocol for co-infected patients at all. But the standard of care for children is now they are receiving integrase inhibitors. This was included in the national guidelines recently. So until a couple of years ago, they were restricted to receive all drugs. But now they can access Haltegravir, dolutegravir in the pediatric formulation. So is similar to that first-line therapy for adults.
Can I make a comment about this? A question to you, to Dr. Calimera. We in the past using raltegravir plus ACT in 10 patients with the HAM-TSP. And then we saw in the first 6 months the virus is coming down, and half of these 10 patients stopped the evolution from. But then after 6 months later, they have relapsed, and they follow up the natural history from this disease. I feel in the future probably we need to have combination. If we're planning to do treatment, probably we need to ask in the option, what is your opinion to try to choose 2 drugs, not in related one. Of course, we need to have one clinical trial with one, but then we need to add, because you remember when we started HIV, we give one, then we use 2, but still you have late relapse. And it will be very important to see if we need to have 2 drugs or 1 drug to try to reduce the very important impact. Graham, and there are 2 questions there.
You were first. Fernanda, thank you for your presentation. I wondered if you were planning, or whether you have enough data to do some regression analysis to look at associations, because you've seen percentages of rates of infection and so forth, but there are differences within your groups, even though they were often people that were coming to clinic with your patients. I think I understood that correctly. But are there other explanations that we need to eliminate before associating higher rates of HPV? That's the first question. And then the other bit, which I didn't understand, was how do you think a particular subtype of HPV becomes more common in people with HTLV?
The type of HPV depends on the circulation of the virus. I think HTLV patients have a different comportment regarding HIV patients, for example. In HIV, we have much more HPV high risk and more persistent because the immunodeficiency is higher in HIV patients, but we don't know really if there is immunodeficiency in HTLV patients regarding HPV. But it's the HPV types depending on the circulation of the virus. And they are, I mean, patients are more, how to say this, more, they have a less partner, for example, than HIV.
Yeah.
But one question that remains is, we don't know if this infection will persist over time. This is a cross-sectional study, so we just take a picture, and now we need more studies to evaluate a long term to see if there is more cancer, or we have to study a higher number of HTLV women infected with HPV to see if there is more cancer. But anyway, I think we should provide vaccination for HTLV infected women. I think this is important.
Thank you.
Please.
Fernanda, first, congratulations for your data and presentation. And my question is, I didn't see if you sequence the HPV, because I saw that you showed the genotypes, but I don't know if you sequence, because my suggestion for you, and my question also, is if you sequence, it's important, I think, to study the coevolution between these two viruses in this patient, trying to make the complete genome.
We did next generation sequencing and Sanger. We do both. And with NGS, we could see multiple infection, so 4 or 5 subtypes.
Okay. But you make the evolutionary analysis comparing the coevolution.
You need to
That's
do
very
this.
important.
I don't know how to do this.
Okay, thank you.
Pazzo, do you want to answer the question of Dr. Gattuso? I don't? Okay. No, then I think, just to answer your question about co-treatment, I think it's absolutely essential. I think what Pazzo was referring to in our in vitro studies, we know they work, but in the context of patients, there's still one question that we don't know, right? Will resistance occur? And we have to look at the efficacy, but we also have to look at will resistance occur in the future, and we have to still be. We know RT is much less error-prone compared to HIV-1 RT, but we still don't know yet what the effect will be long-term, so we do have to keep that in mind. And with that, I had a quick question for you. When you were describing your patients, yes, for you, you say that after 6 months, the proviral load was going back up. I was wondering, did you sequence the proviruses? Did you have any idea whether the virus became resistant to the drugs that the patients were treated with?
No, the patient maintained the drug. And they have, first they have a 50% response, 5 or 10. The other 5 is early HAM TSP. They have very severe evolution, as we expect. But the 10 patients maintained the treatment from 1 year, and then 1 year, the other 5 who have stopped the evolution, they start to. The virus load was high, and then the patient started to have the same symptoms of evolution. Probably we need to extend the study, of course, but the early response was not good from the study. That's the reason why we closed this. But that experience is very important for us to see transitory effect of this raltegravir. Remember, 6 years ago, the first study was raltegravir in vitro. But right now, dolutegravir have the barrier from resisting in comparison with the raltegravir, and probably that is one of the reasons we can use and this safety in pregnant women, etc.
Yeah, exactly. Thank you.
It's a question for Dan, but I also want to hear about our colleagues who are living with HTLV in relation to targeted testing in antenatal clinics. And 30 odd years ago, we looked at this for HIV, and it doesn't work. It's stigmatizing, and we don't pick people up, and it just doesn't work. Isn't it much better to actually offer HTLV screening to everybody, and then it's part of the normal care, even if that means you have to find ways of making it cheaper in the laboratory?
So yeah, I would agree with you, and I know, well, from Japan, there'll be colleagues who'll be able to, comment quite deeply on their experience of the benefit of that national screening program. I think the difficulty is obviously the politics and the fact that, Graham and others will know better than I, that multiple occasions the UK National Screening Committee have turned down the proposal. And so really for pragmatic reasons, I think they in fact invited, is my understanding, a targeted screening proposal. So I suppose it's just being pragmatic, it's somewhere to start, but I completely accept it's not ideal, and my colleagues working in hepatitis C have said the same, that targeted testing of hepatitis C is stigmatizing, but it's purely pragmatic, I think.
Thank you. So thank you to all our...
their opinion.
So I will translate what Marcia was telling here. So she's saying that if it's not possible to test everyone, so maybe we should start testing for those women who are from high endemic countries that we already know that have high prevalence. And then she's saying that, of course, we will have a stigma as well, but she thinks that they should test if possible. Yeah? And she's saying also maybe refugees as well. So I think she agrees, if not possible testing everyone, at least start with those with higher risk.
The last question, please.
Okay, thank you. So, Dr. Rios, it was an excellent presentation, and all of the talks as well. And I have a specific question, and also a commentary. So, in Peru, we previously made a publication about. We found that in the National Cancer Center, the leading cause of cancer related to HTLV1 is not ATL; it's actually cervical cancer. And also we found that it was mostly frequent in the Amazon rainforest than the highlands. So in the highlands, we found a lot of ATL, but in the Amazon rainforest, practically all the cases were cervical cancer. So there is any relationship or probably the same situation in Brazil? I would like to know. Yes.
This is the main cause of cervical cancer in Brazil is HPV infection. And we include the HPV vaccine in the national vaccination calendar. I don't know if it's like that. It's included, is provided to all children, men and female. Yes, there is difference. You mean the subtypes? Yeah, the subtypes, they circulate in regions. We don't know. I don't know if we have this. Maybe the INCA, the Instituto Nacional do Câncer, that collaborate with us. Maybe they know this. They have this chart with all subtypes. I don't know. But I was surprised to see that 58 was very frequent in our samples. I saw some articles in the Northeast, in Brazil, in Rio Grande do Norte. They had also this subtype. But I think it depends on the region, yeah.
We have a sample of MSM we tested for HPV recently, and over 35 different subtypes, very common, very frequently diagnosed in this population. So, as Fernanda said, you expect to have all the subtypes disseminating around the country.
Right, so clearly I think the conversation could go on. Thank you to the speakers for a very stimulating session, and I'd like to thank you again.